a sacrospinalis splitting approach, or the so-called Wiltshire approach, is a far better approach because you don't have to work as hard against the posterior musculature. And it can, in practice, I would use a single midline skin incision, retract the subcutaneous tissues on each side and undertake separate fascial incisions for the Wiltshire approach. The way that this model has been put together, they've put a cassette of the spine model in, which they haven't yet welded the skin to, so we've already got 2 incisions, so I suppose we could just use those incisions and approach through the muscle. I haven't done this at all before with a model, so I'll be discovering how it works. Oh, what's that? Oh, that's the ilium. That's a joint, isn't it? Yep. Which joint is it? Is that a sacral foramen here, maybe? Well, that's a lamina, isn't it? That means there should be a joint out here.
It's definitely tough.
See how to retract this softly? Yeah.
That's a joint there. Where's the transverse process? We'll cut this. If we just cut it like this, and then we can make out that we developed it by blunt dissection.
Just like the real thing.
So the beauty of the sacrospinalis muscle splitting approach is that you get a direct line of view along the pedicles. You're not having to fight against the muscles. If you do a midline exposure, you've got to work very hard against the muscles in order to gain exposure of the facet joint and the transverse process. For the purposes of this demonstration, we have a syn frame in position, but ordinarily we would use a Kean-Cohen self-retaining retractor and usually a Mollison. And it's a muscle-sparing approach, so you're dividing a natural plane within the muscle. It's usually necessary to divide some of the multifidus distally, but in general it's a muscle-preserving approach. And then the exposure involves subtotal resection of the L5S1 apophyseal joint, which is that's the inferior facet of 5 there, superior of 1 adjacent to it that you might be able to see on the edge of that frame there. And then we've got the transverse process of L5 and the pars of L5. So you need to decorticate a C-shaped area, a reverse C, from the superior articular facet of S1, inferior of L5, the pars, and the transverse process. And usually dissect everything from a bony anatomy point of view down to the plane of the transverse process, which is deep in the depths here, and you'll see in between movements. This bone's actually fairly realistic, I have to say. I'm not sure if it's got cortical and cancellous. It looks like it does. So if we begin at S1, we use a landmark, the base of the superior articular facet, adjacent to the groove in the alar. Recognise the angle according to X-rays, angle medially, and then advance the awl, seeing the pedicle awl, usually with the flat surface of the awl adjacent to the spinal canal. Advance, turn it, advance, turn it, advance, and then use a feeler to make sure that we have bone on all sides, although you can use navigation. You want to use a solid end point and withdraw, feeling all sides. I use a depth gauge to assess the depth. And at this point we're going to put a 40mm screw in. So we have a screw loaded. This is a self-tapping screw. We're fencing a little bit with the instruments here, but advance this into S1. So using a starting awl, make a starting position at the base of the transverse process, advance it. So advance the awl, twisting as we go, feeling that the bone's got a homogeneous consistency to it, so you're not having a whoopsie outside of the pedicle. Withdraw the awl, use a feeler, again to make sure there's bone on all sides, there's a solid end point. Use a depth gauge to confirm the depth, which in this case is 45 millimeters, but we use a 40 millimeter screw, and then insert the screw. So having seated the screw, try to make sure the head of the centre tab is mobile so you're not impinging against the joints above, and line them up in order to accept a pre-contoured rod. So place the rod in the extended tabs and then use T-handle.
Yeah.
So this spins down, don't tighten it yet, just leave that little loose, and try not to have the rod too proud at the top. Again, place the T-handle, the back turn, then spin this down. So turn this until it clicks off. Do the same at the level below. Approach, but with this the muscles come back over this area. There's less blood loss, better preservation of the muscles and the midline structures, and less destruction to the posterior structures. All posterior surgery unfortunately involves damage to tissues. And then once you got onto the spine itself, the disc was quite realistic. In fact, a degenerate crumbly disc would be crumbly like that inside. And the removal of that was reasonably realistic, and the insertion of the cage and the plate were quite realistic, but for the purposes of the demonstration it would be easy to use a longer plate so that it fixed solidly on the front of the spine. And then this would be a very good module to do an anterior and a posterior fusion, because it's something a lot of people do. And then when you get to the spine itself, it's good. It looks like a proper spine, and the bone felt like a proper bone. The pedicle felt like a proper pedicle. The screwing in was like a proper bit of bone. And so that part of it worked pretty well, I thought. It's quite a realistic model for dissecting through, getting the peritoneal sac. It's pretty good. And once you get to the disc, it's very good.
Yeah.
So you could definitely show surgeons how to do an operation with this, probably better than on cadaver or whatever.